Good evening, all the delegates. I welcome you for today's 24th Masterclass lecture on diagnosis and management of Megaloblastic Anemia. And the teacher for today's Masterclass is Dr. Jeena Bhattacharya, Professor and Head, Department of Clinical Hematology, Guwahati Medical College and Hospital, Guwahati. Over to you, ma'am, please.
Good evening. I am thankful to ISSBT for giving me this honor to take the class today. Today's class is on the diagnosis and treatment of megaloblastic anemia. Megaloblastic anemia, as we know, is a macrocytic anemia. And this is what happens. The red cells are large, very big. And this happens because of megaloblastic changes of the precursor to the red cells in the bone marrow. So in the picture, you can see red blood cells which are large and big. And this is so big sometimes that it can be as large as neutrophils. And on the lower side, lower panel, you can see the megaloblastic changes in the bone marrow. Okay. So what happens why does it happen? Why there is a megaloblastic changes or why the cells become so big? Because there is a asynchronous maturation between the nucleus and the cytoplasm. And this is as a result of impaired DNA synthesis, which is due to the megaloblastic anemia. In comparison to the DNA synthesis, RNA and protein synthesis is less impaired. Therefore, the nuclear maturation lags behind the cytoplasmic maturation. So this is why we see large cells in the bone marrow, which is reflected in the peripheral blood smear as macrocytes. And this is because the nuclear maturation is lagging behind the cytoplasmic maturations. This entity was described in cases way back in 1800. And later on, after many years, these were diagnosed to be having pernicious anemia, which is a form of megaloblastic anemia only. And many of the patients, died because of this disease because there was no treatment available. Subsequently, the treatment was developed, and in 1930, three scientists, Murphy, Minot, and Whipple, got the Nobel Prize for the development of treatment of megaloblastic anemia for these patients. So we know there are two main causes of megaloblastic anemia. One is vitamin B12 deficiency, and second is folic acid deficiency. Other uncommon causes are copper deficiency and thiamine-responsive megaloblastic anemia, which is a rare hereditary disorder. Our focus today will be deficiency of vitamin B12 and folic acid. So these two are very important parameters, which is crucial for DNA synthesis. We know the folic acid supplies methyl group, and this acts as a one carbon donor in the DNA synthesis. And in this reaction, vitamin B12 acts as a cofactor. It recycles 5-methyl tetrahydrofolic acid to tetrahydrofolic acid, and this then converted to different forms to act as a one carbon donor. So that means folic acid is the donor of one carbon in the DNA synthesis, and vitamin B12 acts as a cofactor, and it produces the tetrahydrofolic acid, which is required for in the subsequent reactions to give the one carbon donors. And while doing that, vitamin B12 also converts homocysteine to methionine. And this particular phenomenon is depicted in this figure. As you can see here, this blue arrows has shown where the folic acid and vitamin B12 acts in this particular methionine cycle and folic acid cycle, which ultimately leads to the synthesis of the DNA. I think it is clear to you, all of you, that vitamin B12 acts as a cofactor, and it converts methyl tetrahydrofolic acid to tetrahydrofolic acid. And this tetrahydrofolic acid subsequently in subsequent reactions finally lead to DNA synthesis. So folic acid requires for conversion to tetrahydrofolic acid vitamin B12 as cofactor, and this vitamin B12 again is essential for conversion of homocysteine to methionine. So we should understand these two reactions. One is vitamin B12 as cofactor in conversion of methyl tetrahydrofolic acid to tetrahydrofolic acid, and the subsequent reactions when the folic acid converts into thymine and finally leads to DNA synthesis. And when there is a deficiency of these two vitamins, that results in DNA synthesis impairment. And as a result, the cells are arrested in DNA synthesis of the phase, resulting in DNA replication errors, and patient cells undergo apoptotic death. So this leads to two major effects on hematopoiesis. As we have already seen that megaloblastic changes occur, and this is because of the nuclear cytoplasmic dyschrony. Nucleated precursor cells in the bone marrow, all cells, myeloid cells and erythroid cells would become abnormal, and you can see giant metamyelocytes in the bone marrow. On the other hand, because of ineffective erythropoiesis, there is intramedullary hemolysis occurs, and because of that, we'll see a hypercellular bone marrow, whereas there is peripheral cytopenia. This is one of the causes of hypercellular bone marrow with peripheral cytopenia. There will be evidence of hemolysis in the blood, like LDH will be high, haptoglobulin will be low, and there will be unconjugated hyperbilirubinemia. Reticulocyte count will be low characteristically because of ineffective erythropoiesis. We know that vitamin B12 also is required for myelin production for neurons, and deficiency of vitamin B12 therefore will lead to neurological syndromes. However, exact pathophysiology of neurological dysfunction is not known. So let us understand how the vitamin B12 is absorbed in our body. And it's a very interesting phenomenon. There are many factors involved in the absorption. So firstly, we must know that vitamin B12 is in the food is bound to protein. So for absorption, it requires a factor known as intrinsic factor, which is released in the stomach. And this intrinsic factor and vitamin B12 then come to the terminal ileum, where it gets absorbed, and subsequently it is delivered bound to the transcobalamin, which is then rendering the vitamin B12 available for cellular uptake. So these are the major steps, and let us understand these steps in this figure, which is nicely given here. As you can see in the diet, vitamin B12 is bound to the protein. This is the vitamin B12 molecule, and this portion is the protein. Once we swallow, once we eat the food, it comes to the stomach. In the stomach, because of the acid and pepsin that is there in the stomach, it will dissociate from the protein that is there in the food, and B12 is released. And because it is not a ideal milieu, so the salivary glands will release our binders, which is also known as haptocorrin. This haptocorrin will come to the stomach and bind this released vitamin B12, and this complex will then go to the small intestine, and then in the small intestine, pancreatic enzymes will split this from the haptocorrin, and vitamin B12 molecule again is released. Now, the role of intrinsic factor will come. Intrinsic factor is released in the actually stomach by the parietal cells, and once it is released, it will come to the small intestine, and then it will get attached to the free vitamin B12 molecule, and thus it forms a complex known as intrinsic factor B12 complex. This is very important step, and with this, once this complex is formed, this will come to the ileum, and in the ileal cells, it will get absorbed by receptor-mediated enterolysis. And once it is absorbed into the cell, it will then dissociate from the vitamin B molecule, and vitamin B molecule will then bind to transcobalamin, which is a transporter of vitamin B12 molecule. It will transport the molecule to the blood, and subsequently it will be available for cellular uptake. So these are the steps involved in the absorption of vitamin B12. The subsequent figures says the similar thing. It is the same thing that has been depicted in this figure, because a very well documented and well this thing, I think it will be easier for you to understand. That is why I have kept these figures for you. Now, for folic acid, it is readily absorbed. We do not have any other factors required for absorption of folic acid. Directly, once we inject, it will directly go and absorb in the proximal jejunum of the intestine. So now let us look at the different causes of vitamin B12 deficiency. In India, most common cause is nutritional, as we all know. especially those patients who are vegans, who do not eat, not even eat dairy products, any animal products, vegetarians. And in infant, we see those who are breastfed and the mother is a vegan. So in those situations, we can have nutritional deficiency of vitamin B12. And subsequently, we now have understood about the absorption of vitamin B12. So then you come to the gastric abnormalities, any surgery, and if the intrinsic factor is not produced because of different causes like autoantibodies against the intrinsic factor or parietal cell antibodies, which is well known as pernicious anemia, then it will lead to vitamin B12 deficiency. It is more common in Western population than in India. We hardly get to see any cases of pernicious anemia in our clinical practice. Small intestinal disease like any surgery or bypass surgery, malabsorption, celiac disease, Crohn's disease, anything that will hamper the absorption of vitamin B12 will lead to megaloblastic anemia. Even pancreatic insufficiency, because it's important that pancreatic enzymes has important role to play in the absorption. So chronic pancreatitis, when it is very severe, will lead to megaloblastic anemia. Drugs that we commonly use like PPI, ACE2 receptor antagonist, metformin, which is now used commonly for diabetic patients or pre-diabetic patients, can lead to megaloblastic anemia due to vitamin B12 deficiency. And inherited disease is a rare cause of vitamin B12 deficiency. When you look at the folic acid deficiency, again, nutritional deficiency is one of the commonest cause. This is mostly because of poor intake, or because nowadays we have many young adults coming to us with substance use who are deficient in folic acid. Chronic alcoholism is another cause of leading to folic acid deficiency, and many a time overcooked food, which is mostly done in elderly population or sick patients, can lead to folic acid deficiency. And rarely, nowadays it's very rare, but if the infant is fed with goat milk only, then it can lead to folic acid deficiency. As in vitamin B12 deficiency, anything to do with malabsorption can lead to vitamin B12 folic acid deficiency as well. And drugs is an important factor to cause folic acid deficiency, especially the drugs that we commonly use for the treatment of leukemia and autoimmune diseases like methotrexate, hydroxyurea, trimethoprim, and also phenytoin. And we all know during pregnancy and in case of chronic hemolysis like thalassemia and other conditions where there is increased requirements of folic acid, these conditions can lead to folic acid deficiency. So let us look at the dietary sources. We know that vitamin B12 is not produced in the desiccated and is not available in vegetables. It is only available in animal products, meat, dairy products, and eggs are the common sources of vitamin B12. However, folic acid is available in fruits and vegetables. Mostly the dark green leafy vegetables are very rich source of folic acid. Let us see at the requirements. The requirement is very less, 0.4 microgram to 2.4 milligram in adults and children. And total body store for vitamin B12 is 2 to 4 milligram. Therefore, when you look at the requirement, the deficiency to occur, it will take about 3 to 4 years time. From the depletion of store to the manifestation of the disease, it will take 3 to 4 years. However, in folic acid, it is less. That store is 5 to 20 milligram, and deficiency manifests within 3 to 6 months of depletion of the store. So, looking at infant, megaloblastic anemia is rare in infant. However, when the mother is breastfed and is strictly vegetarian, then it can lead to megaloblastic anemia in infant. So we should be having a high index of suspicion because in infant, there is no hepatic reserve. So vitamin B12 deficiency or megaloblastic anemia can develop as early as 2 months of age. Therefore, we should be, be having a high index of suspicion when the mother is vegetarian and child is breastfed. And we know combined deficiency is very common in our scenarios. Nutritional deficiency can lead to combined deficiency, malabsorption, surgery, all can lead to deficiency of both vitamin B12 and folic acid, leading to megaloblastic anemia. So this is an older adult, is a special population. Here, the problem is release of vitamin B12 from the food. because we know that cobalamin or vitamin B12 is tightly bound to food, and it is split and released in the stomach by acid and pepsin. In older adults, because of achlorohydria, this split is defective, and this will lead to deficiency of vitamin B12, causing megaloblastic anemia. So you also should know about the acute onset of megaloblastic anemia, which can happen. We know that it takes 2 to 4 years, but sometimes we can even get acute onset megaloblastic anemia in patients who are in ICU, getting multiple transfusion on dialysis or on TPN. And it is a very well-known fact that when we give nitrous oxide anesthesia, this nitrous oxide inactivates vitamin B12, and this leads to inability of the factor to take part in the reactions, leading to development of megaloblastic anemia. So genetic disorders are rare, and so we have hardly seen any cases of genetic disorders in our clinical practice. So let us look at the clinical manifestation of megaloblastic anemia. The clinical spectrum or disease spectrum is heterogeneous megaloblastic anemia. It can be broadly divided into hematological or non-hematological. And non-hematological causes, amongst the non-hematological causes, we have seen gastrointestinal, because the entire GI tract is involved in the absorption of vitamin B12 and folic acid. Neuropsychiatric, because of defect in the neurons, and there are other manifestations. So what are the common clinical features? This is the common clinical scenario that we see. Signs of anemia, signs and symptoms of anemia. Patient will come to you with easy fatigability, weakness, palpitations, and chest discomfort. Many a time they will land up with cardiologists because of chest pain. And these are the symptoms of anemia, and it can elicit that the patient would be having pallor and very mild jaundice, which we used to call as lemon yellow color. And combination of anemia and mild lemon yellow jaundice will give a clue that this patient might be having megaloblastic anemia. If it is associated with glossitis, like pain and swelling of the tongue, tenderness, loss of papillae, and if there is hyperpigmentation like this in the tongue, then your suspicion is stronger. You can see glossitis, loss of papillae, and probably this patient also has angular stomatitis. Some patients would be having oral ulcers, and clinically, when we examine for systemic examination, on the serious examination, we may see a hemic murmur, and on abdominal examination, we may see a splenomegaly. So these are the common clinical features that we get to see in a patient of megaloblastic anemia. Specifically, when you see anemia and jaundice, and when you see a glossitis with angular stomatitis and some pigments in the tongue, then you can strongly suspect megaloblastic anemia for this patient. And when we have seen hyperpigmentation, and this is a very commonly seen in our clinical practice, hyperpigmentation specifically on the knuckles. And when we see something like this in a patient who comes to us with anemia, then our diagnosis is almost done. Specifically, when it is associated with something like this, glossitis, and some pigmentation in the tongue also, then we know that this patient has megaloblastic anemia, and we just need to confirm the diagnosis by doing the diagnostic test. So this is easy, but many patients would come to you with neurological syndromes, and this can occur without manifestation of any hematological symptoms like anemia or signs. So common neurological findings that is seen is most commonly paresthesia. Patient will come to you with tingling and numbness of the limbs, mostly the lower limbs, and patient can have some movement disorders like gait problems, ataxia. And when you see, the neuropathy is typically symmetric, and both sides of the limbs. I mean, patient would not say that they have only one limb is affected. Both limbs, all the limbs can be affected. And when the disease is very severe, the brain is involved, and this can lead to dementia and other neuropsychiatric manifestation. We are very familiar with this subacute combined degeneration. Here, this is a classical finding, neurological finding or neurological description for vitamin B12 deficiency, subacute combined degeneration of the dorsal and lateral column. And this is associated, this happens because of demyelination of the spinal cord. And when the patient has B12 deficiency, that will be progressive weakness, movement disorders, and paresthesia, which may, if we do not get treated, will progress to spasticity and paraplegia, which may later on may become irreversible. So it is very important that we should identify this entity and treat as early as possible. So when the patient would be seen by an internist or us or a neurologist, we can elicit certain signs like there will be impaired sensation of position and vibration. We can elicit weakness, which can progress to paraplegia, or sometimes patient can also have incontinence. One typical sign is a Lamid sign, where a patient would have shock-like sensations when a patient flexes his neck. This is because of the radiation, and this the pain will radiate to the feet. Rhombus sign would be positive. All the deep tendon reflexes would be abnormal, and there may be extraperoneal signs also. Some patients would be also having restless leg syndrome. And psychiatric manifestation is also variable. Patient can have depression, irritability, forgetfulness. Dementia is seen in very severe deficiency of vitamin B12, and also visual disturbances because of optic atrophy. So there are very psychiatric manifestations that is seen in megaloblastic anemia. So we should not be focusing only on anemia. Patients can have these manifestations without even having any anemia. So our index of suspicion should be very high so that we do not miss a case of megaloblastic anemia. So before going further, let us relax and discuss a case which presented with a very atypical presentation, 15-year-old girl, and she was admitted in psychiatry department because of depression, severe depression. She also had associated symptoms of numbness of extremities. Her hemoglobin was 8 gram. Because she was having depression, it was attributed, and her considering her age, it was attributed to iron deficiency anemia, and she was getting oral iron. However, she continued to have complaints of numbness on all the limbs. Therefore, a neurologic call was given. And the neurologist asked for estimation of vitamin B12, which was come as very low. So she was diagnosed to have associated on top of depression. She was found to have associated diagnosed to have associated megaloblastic anemia, probably nutritional, and she was given parenteral hydroxycobalamin. So in 3 months, her symptoms disappeared. Her numbness, paresthesia were gone, and therefore she was put off vitamin B12. Then she was lost to follow-up. After about a year, she came back with very severe symptoms with gas and gait abnormality. And this time, she was put back on vitamin B12, and this was continued lifelong. And when she came back, she is on regular follow-up, and on 3 years of follow-up, she is now better and requiring no medicine, neither for depression nor for any other illness. So the point here is that we missed her diagnosis initially because our history taking was not complete. In the history, when the parents later on mentioned that she had undergone some surgery where some portion of her intestine were removed, and this was missed in the history, and we also missed this in the clinical finding as well. And besides, because she was admitted in psychiatry department, entire focus was not in megaloblastic anemia, it was on her mental condition. So let us now see how we approach in a diagnosis of multiple myeloma. So as this case has illustrated, the history taking is very, very vital, and it's a first step towards making a diagnosis, because it can cleanse the diagnosis many a time, or it can give important clues. And this must be followed by a thorough clinical examination. We must see the patient in detail, not not doing clinical examination and only focusing on investigation. So first test that we do for such cases is a complete blood count. This picture is not very clear, but you can see here the MCV is 112, hemoglobin is 9, total count is low, and platelet also is on the lower side. I do not know whether you can see, but I can see the platelet is about 1 lakh. So here, this patient has some amount of pancytopenia with macrocytosis of the RBCs. And when it is more than 110, then we consider this as megaloblastic anemia, if proved unless proved otherwise. And when the PBS was looked at, it had shown hypersegmentation, and cells were like big, RBCs were as big as this one, macrocytes, and there is hypersegmented neutrophils like this. So when we see something like this, after the clinical examination, then we can almost make a diagnosis of megaloblastic anemia. There may be other changes in the peripheral blood as well, like Howell-Jody bodies, basophilic stippling also can be seen, Cabot ring also can be seen. And in very severe megaloblastic anemia, we can see something like this, which is, with the ominous sign for us. Whenever we see cystocytes, we are worried that this patient might be having TTP, but this is and this can be seen in very severe megaloblastic anemia, which can lead to a misdiagnosis of TTP. So classical CBC finding is a macrocytic normochromic anemia. There will be anisopoikilocytosis, RDW will be raised, leukopenia or thrombocytopenia would be there, might not be there. Sometimes it is, most of the time it is mild, but sometimes it can be very severe. In our clinical practice, we have seen very severe thrombocytopenia, even leukopenia associated with megaloblastic anemia. And this is one thing, hypersegmented neutrophil, when you see, and when we see more than 1% of neutrophils with 6 lobes, and more than 5% neutrophils is 5 lobes, then we label the patient, or we define it as hypersegmented neutrophil, and then we have a strong evidence of megaloblastic anemia. So classically, when we see something like this, we expect that bone marrow will be hypercellular with megaloblastic maturations. Even the myeloid lineage will show gigantism in metamyelocyte and myelocyte, and neutrophils will be hypersegmented. Megakaryocytes also become large and hyperloid. So there will be dysbiosis in all the cell lengths in the bone marrow. As you can see here, megaloblast very typically seen in megaloblastic anemia. You can see the giant band form and hypersegmentation here and in the peripheral blood as well as in the bone marrow. So when we see something like this, then our suspicion becomes stronger. Now the question is, do we need to do a bone marrow examination for diagnosis of multiple myeloma? The answer is no. In a typical case, it is not necessary and it is not recommended. However, when we have difficult cases, in rare cases, occasions only, bone marrow is done when there is pancytopenia or some other problem where we have some doubt in the diagnosis. So when we do the blood test, biochemical test, then there will be evidence of hemolysis, indirect hyperbilirubinemia, high LDH, low haptoglobin, other changes that you see in the biochemical parameters. And this is the result of ineffective erythropoiesis because of intramedullary hemolysis. Also, there will be some amount of peripheral destructions because the large RBCs undergo damage because when they pass through the spleen. So next step is the estimation of cobalamin assay and folic acid assay. If it is less than 200, it indicates deficiency of vitamin B12. If the folic acid level is less than 4, then it indicates deficiency of folic acid. However, many a time this test may not be available with you. Then in a typical case, we can give a therapeutic trial And when we give a therapeutic trial, even one dose will give rise to immediate subjective improvement. Then we can assess if there is any response on by day 7 by doing a reticulocyte count. And if we have access to bone marrow, then the morphological changes will appear within hours of starting treatment. So therapeutic trial is one option for making a confirmatory diagnosis of megaloblastic anemia. These tests were not easily available and not commonly done. Serum homocysteine and serum methyl malonic acid level, and these two levels are increased in vitamin B12 deficiency. However, in folic acid deficiency, only serum homocysteine will be increased. So these two levels can differentiate between megaloblastic anemia and folic acid deficiency. Holotranscobalamin is a relatively new assay, and it is also not done routinely. It is a biologically active form of cobalamin. It can be helpful when cobalamin assay is not conclusive. So once we have a diagnosis, then we have to focus on the treatment so that the patient gets treatment early, so that the patient doesn't have any irreversible damage of the neurons. And once you take care of that, then next step is to find out the underlying cause. So we must look for any antibodies if there is any, which is not common in our country. However, we may get to see some rare cases, and any abnormality in absorption, doing imaging, endoscopy, and under test, so that we find out the exact cause and treat that underlying cause as well. So there are several challenges in diagnosis, which is known as diagnostic traps. So what is that? Many times we can get normal MCV, specifically when there is coexistent iron deficiency, coexistent thalassemia, especially a patient of beta thalassemia trait can be asymptomatic and can have severe megaloblastic anemia with a normal MCV. So we should not forget this. Therefore, examination of peripheral blood is very, very important besides the clinical examination, because the patient will be having clinical evidence of megaloblastic anemia in the form of glossitis, anglostomatitis, and other oral ulcers. And we have to look at the peripheral blood space to show us dimorphic population of cells, microcytes, and also macroveilocytes. And if we see hypersignia neutrophils, that will cleanse the diagnosis, even though MCV is normal. And when we have neurological impairment, it has been reported that about 1/3 of the cases, patients may not be having an elevated MCV. So in these situations, usually the RDW will be significantly raised, which can maybe sometimes give you a clue for the diagnosis of megaloblastic anemia. Now again, pancytopenia can sometimes be misleading. Many patients can have very severe pancytopenia. And so we know that pancytopenia can be an underlying cause of acute leukemia, specifically acute promyelocytic leukemia. Patient can be having severe aplastic anemia. So we have to be aware of these entities. And however, even in presence of pancytopenia, if there are typical features of anemia, jaundice, glossitis, knuckle hyperpigmentation, then we should not be worried. We should not do bone marrow immediately. We should be giving a vitamin B12 and folic acid trial, or do the test, and then our diagnosis will be confirmed. Many a time we may end up not doing the bone marrow test even in presence of pancytopenia. So many time, even if we do a bone marrow, it can mimic a myeloid neoplasm. Myelodysplastic syndrome is a very close diagnosis, because in megaloblastic anemia, there will be a lot of dysbiosis in all the cell lines. And sometimes even acute leukemia can be misdiagnosed. I mean, megaloblastic anemia can be misdiagnosed as acute leukemia, especially acute erythroid leukemia, because of presence of increased number of erythroblasts with megaloblastic changes and associated dysbiosis. Therefore, we have to have high index of suspicion to make a correct diagnosis, especially in a setting of pancytopenia. So I have already discussed about it. When there are cystocytes, there's an entity called pseudothrombotic microangiopathy. And severe vitamin B12 deficiency can be one cause. Therefore, it is essential to distinguish TTP from megaloblastic anemia mimicking TTP, because we know the cystocytes is an ominous sign, and TTP has very high mortality. Unless until we diagnose TTP very early, a patient may die. Therefore, it is very important to distinguish between TTP from megaloblastic anemia mimicking TTP. And in TTP, we will see cystocytes, thrombocytopenia, which also we can see in megaloblastic anemia, and high LDS. All this can create confusion in diagnosis. Another entity is persolated megaloblastic anemia. In very severe megaloblastic anemia, when we treat, many patients will come to us with treatment with multivitamins, which would be having some amount of vitamin B12, folic acid, and other vitamins. So this can modify the morphological features. However, some patients would be, however, we have to look at the peripheral blood smear closely to look for any hyperpigmentation or giant bands and other features clinically. So some laboratory pitfalls also are there. Sometimes there may be false negative or false positive reports are also available because of various issues, technical or otherwise. And there are certain conditions like even HIV virus, anticonvulsants, and myeloma and other drugs can cause seriously low vitamin B12 concentrations. On the other hand, diseases like alcoholic liver disease, myeloproliferative neoplasm, and other diseases can result in falsely high vitamin B12 estimation. Sometimes we see, because of presence of intrinsic factor antibodies, this can interfere with the assay, and we can have falsely normal or high values. And also multivitamins, when is given before the treatment, before we do the assay, can modify the results. So when with this background, diagnostic backgrounds, diagnostic traps, and diagnostic dilemmas and pitfalls, let us look at, once we come with the diagnosis of megaloblastic anemia, let us look at how we manage such a case. So management of megaloblastic anemia, we can divide into treatment of the deficient factor, and then we have to focus on the treatment of the underlying cause, and also the treatment of the associated conditions like iron deficiency, anemia, worm infestation, and others. At the same time, we should not forget about giving the adequate dietary advice. These are the components when we take up treatment of megaloblastic anemia, and we should be sticking to this. So treatment of the deficient factor is by supplementation, because we have to start the treatment as early as possible, because if we delay, then the neurological symptoms, it may become irreversible. So what are the choices that we have? We have cyanocobalamin, hydroxycobalamin, metocobalamin. These are all available commercially and available in different formulations, oral, intramuscular, intranasal. Which route is preferred? For those patients who are nutritionally deficient, then oral supplements should suffice. However, when the disease is very severe and the cause is the permanent damage or damage to the absorptive surface of vitamin B12 folic acid, then we have to resort to parenteral supplementation. The recommended regimen is 1000 microgram every week. Sometimes we give twice weekly also, and this to be given intramuscularly. And by 8 weeks, 2 months time, patients would hemoglobin would improve. And for those patients who need long-term treatment, then for cyanocobalamin, it will be given monthly, and for hydroxycobalamin, it will be given every 3 months. For supplementation for treatment of vitamin B12, intravenous injection is not used. Vitamin B12 and folic acid deficiency can be dual. And in those situations, in such situations, always remember, do not start with a folic acid tablet, which is easily available, we must correct the vitamin B12 first, because if we give only folic acid and do not treat vitamin B12, then it can lead to severe, it will mask the severity of vitamin B12 deficiency, because it will correct the anemia and patient will end up having subacute combined degeneration of the spinal cord. So question is how long to continue the replacement. As I have already mentioned, those patients where the underlying cause is irreversible, then we should give the treatment for lifelong. And when the treatment, the cause is reversible, then we treat till the deficiency is corrected and the symptoms resolve. And this will usually take place in 3 to 6 months' time. We have to give proper counseling for compliance, otherwise patient will come back to us repeatedly with the same problem, same symptoms. So corrective dietary measures and other measures needs to be given and patient to be counseled on compliance and diet. So do we need to give prophylactic treatment for vitamin B12 and folic acid? Yes, it has been given nowadays for a special population of people who are elderly and they have developed vitamin B12 deficiency. As I have already mentioned, there is difficulty in absorption. Therefore, prophylaxis daily oral vitamin B12 is recommended. And this is, even small doses will do, but daily vitamin B12 supplementation will help this patient and as a prophylaxis. And now, once we take care of the deficiency, then we have to focus on the underlying cause, treatment of malabsorption. We have to take help of the gastroenterologist. And there are cases where H. pylori has been reported to be associated with causation of pernicious anemia or megaloblastic anemia. So eradication will take care of that. And there are other measures like anti-helmintic treatment needs to be given. And I have already mentioned that coexistent conditions needs to be treated, like iron deficiency anemia, which is commonly seen in our patients with megaloblastic anemia. So in certain situations, we have to do periodic testing, especially for patients who are on proton pump inhibitors or on regular antacids and ST receptor antagonists. Many patients would be taking over-the-counter these medicines regularly for many years, and these patients ultimately can develop megaloblastic anemia. So for them, it is advised to do periodic testing for any evidence of megaloblastic anemia. Even patients metformin should be testing for vitamin B12 deficiency. So the question that is always asked is, do we need to give a blood transfusion for megaloblastic anemia who are severely anemic? The answer is a big no. We do not give blood transfusion to treat megaloblastic anemia. So this concept of giving blood transfusion, which is still practiced, we should start forgetting now. So with this lecture, let us look at our misconceptions and misbeliefs. So in the diagnosis, we should not rule out megaloblastic anemia when there is no anemia. Without anemia also we can have megaloblastic anemia. Without macrocytosis also we can have megaloblastic anemia. And even if the vitamin B12 is within normal limit, if the patient has evidence, clinical and other evidence of megaloblastic anemia, we should not rule out megaloblastic anemia. And we should not think that it doesn't occur in children. It also occurs in children and also in infants. The misbeliefs or misconceptions in terms of treatment is that we always think that oral is as good as parenteral. Yes, it is so, but when parenteral supplementation is required, as in cases of gastrectomy and where the absorption is a problem, then we have to resort to parenteral injection. And once the B12 is normalized, to stop the treatment. Even the patient will stop the treatment at home without asking, and even we should not be stopping the treatment even if the B12 is normal. And also sometimes when the injection is given, B12 go very high, serum B12. But looking at the high B12, we should not be alarmed, and we should not stop the treatment. And many times it is stopped during pregnancy, which is not to be done. So I'd like to conclude with a case. I'm not discussing this case, but I request all of you to go through this case, which will give you some, learning lessons from this case. This was recently published in New England Journal of Medicine, 18 May 2023. And please go through this case, and you will learn many things about megaloblastic anemia. And this was from that case I have picked up. They have discussed a functional vitamin B12 deficiency with nitrous oxide use. So with this, I'd like to conclude by giving you some MCQs. First MCQ is, R binding factor is secreted by, these are the options: parietal cells, salivary glands, pancreatic cells, and ileal cells, intestinal cells. R binding factor is a haptocorrin. MCQ 2, vitamin B12, which is available in all except vegetables, eggs, meat, dairy products. MCQ 3, commonest extrahematological manifestation of vitamin B12 deficiency is anorexia, weight loss, diarrhea, numbness of limbs. Question 4, how rapidly does symptoms improve with vitamin B12 supplement? Hours, days, weeks. Routes of vitamin B12 supplements are all except oral, intravenous, intramuscular, intranasal. And last but not the least, high MCV is not seen in the following conditions. Which condition? MDS, aplastic anemia, hyperthyroidism, acute leukemia. With this, I conclude my lecture. Thank you.